So, good afternoon. Let's start our session. As you know, we do have multiple breakout sessions. So we are dividing, the audience into different places. So at least we have a good number here. So this tells, the significance that you attach to digitalization of health. Which is really, it's great to see you here. So I would like to welcome you to this side event. So let me start by recognizing the presence of Dr. Ahmed Uguel, the Acting Director General of Africa CDC, and Dr. Andrea, the Director General for European CDC, and all of the participants here from member states, partners, all attendees. I would like to welcome you to this important side event on digitalization of health for better health outcome. So if you see what's happening recently on this field, and also the experience from COVID-19, so it looks that digitalization is the future of public health. Whether it's a healthcare service or whether we are dealing on surveillance. So it's important, to digitalize the process, to automate the process, so that it becomes easier to collect information, to correlate it, to visualize, and then to make public health decision. So this has been, considered as a hope, even to to accelerate the progress into the health component of the Sustainable Development Goals. And digitalization of health services is now, a global agenda. So I think most of you know WHO came up also, for a digital health strategy, 2020 to 2025, and Africa CDC under Dr. Ahmed's office. So there is also a big agenda on digitalization of health in general. And in surveillance division, we have been working, for long on health information exchange, to facilitate information sharing across member states in a seamless way, and to correlate, that information coming from member states, and then, make, Africa CDC in a better position to make public health decision making. So you also know that, in healthcare services, digitalization is transforming the way healthcare services are delivered. For example, in Africa, you don't see many radiologists and many, pathologists. However, remote areas have been accessing, through e-health in terms of, getting consultation and interpretation of the lab result, which usually you may not find it in peripheral community settings. So there are a lot to do. And so digitalization of health is also coming with a challenge. So we have a challenge in terms of how we can apply it ethically. It's also challenging, how we can maintain confidentiality, privacy, security. So it will be a lot of challenge. And there are also, many digital solutions, as you know, and at times, it's confusing which one to choose. And many of those are not interoperable. So the whole idea is, we cannot really, harmonize all digital tools, but we can make sure that, they are interoperable. We can ask, countries to use the same laboratory information system, for example, but we work with them in terms of how the different tools can be interoperable. So this is an exciting, topic, and we have really, a long way to go. We are just starting. And I'm looking forward, the conversation during this, side event. And we really will like to listen, like, real-time examples in terms of, deploying digital tools. And we will be listening from presentations how, this digital technology will be helpful in early detection and reporting of, health events. And we will also listen what standards and policies do you consider when you scale up, digitalization of tools? And then in a form of panel session, so we would like to listen from, key representatives of key partners on this digitalization of health. And we will learn from your experience. And our hope is that, you know, these conversations that we started, that we are starting here, will move forward, and hopefully we will form, you know, a strong partnership, so that we push, you know, the idea of digitalization of health in the African continent. We know there are important experiences happening here and there, but it's coming up now with a collective thinking, and then moving this agenda forward. So after saying that, allow me now to call me, you know, Dr. Andre, to give us an opening remark from European CDC. Dr. Andre, please.
Thank you. Thank you for giving me the first shot here, not the host.
Yeah.
So I'm very happy that the second conference of public health in Africa can take place in person after last year's first edition in online. And it's really a pleasure to meet you here. I came straight from the airport. And I would like to thank the colleagues from the Africa CDC to inviting me for this joint event that we have organized here on the digitalization of public health, systems for improved health outcomes. And for me, it is very important that this title already says that digitalization should be for better health outcomes, because it's very easy to get carried away with the technological developments. And in my view, these technological developments should aid and help us to achieve our public health goals, not dictate them. So we have to be very careful and clear. I think we all have seen that besides the immense suffering and pain, the pandemic has also opened opportunities, and the digitalization is one of them that we now should use as long as the momentum is still there. Now, we have all realized, actually also in Europe very much so, that we need to improve our surveillance systems so that they can actually serve in a pandemic. And in order to do this, two things are needed. One is funding, continuous investment, which requires a reprioritization of funding in terms of public health, which we see already dwindling, especially in Europe, where there are much different demands now on the public budgets, and public health is going, well, on the back burner or even further behind. The second part is that we need to develop the skills of the public health experts and the workforce. I mean, the workforce that there is. We all know that there's a significant issue with the workforce, also in Europe, in public health. So that is something that, well, requires a separate seminar, I think. Now, my colleague Gianfranco will later present much more in detail what we have already attempted and how we want to take this forward. In essence, what these new developments mean for us is that we, or have meant for us during the pandemic, was that we identified new data sources. We have developed other outputs that could be updated much more quickly than the usual paper, you know what we had. The opening up of the data. So for all the tables and for all the maps that we have published the underlying data so that everybody could do the calculations themselves. And the creation of a modeling hub called the European COVID-19 Forecasting Hub, with modeling teams in several countries, because modeling becomes an essential part of the surveillance. Now, of course, this has all its challenges, I think, and that is what we have to work together to overcome. Our legal foundation has been amended, and one of the big chunks is the digitalization of surveillance, which means that we have to digitalize an integrated surveillance system according to the state of art. It means also that event-based surveillance or epidemic intelligence should become more effective by using artificial intelligence in the process. And lastly, it will entail that we support our member states in upgrading their systems, because our data are only as good as the data that come from the member states. We also have to pay very close attention that our aim to reduce the inequalities between countries are now, with the digitalization, not even enlarged, but actually help us to reduce them. And from our supranational perspective, this would mean that we have a surveillance system that is interoperable across borders. For the countries, it means that they have a timely and a comprehensive picture of their own situation. But it has also advantages for the single person, because when they have cross-border care, when they go in a different country, then they could just take their data with them. So there is multiple advantages in multiple levels. And it would, of course, mean that combining data from different systems in order to achieve this. And I think, since we are both in the Africa CDC and in the European CDC at the beginning of this, I think it's an excellent, in my view, an excellent topic for our partnership to go with this together. We will certainly find different solutions, but some of the things may also work in both places. So we all know, dear colleagues, that new and disruptive events will happen again. And the world is rapidly changing and becomes more and more complex. All what's going on with the climate change, antimicrobial resistance, the geopolitical changes, the technological changes, make our work more complex. So that means we have to be more anticipatory and more proactive. And we have to work together across countries, across continents, and across the world. And this is what we try to establish with our partnership for the coming years. Thank you very much for your attention.
So, thank you. I think those are important perspectives and considerations in terms of, applying digital solutions. Thank you for, traveling and joining this important meeting. And, we hope that our partnership with European CDC will consider this digitalization as one component, and I think we can move together, very far, and hopefully in one of the forums, similar CPHI meetings in the future, so there will be a possibility that we can share even some best practices in terms of, applying these digital technologies. And I would also like to re-emphasize the importance of using technologies that we applied for COVID. There were really, very important, even to some extent of even applying, artificial intelligence and data systems established for COVID-19. And those should be really, those should help our surveillance program. And we have seen in some countries, like, for example, if I can single out one country in Morocco, they used, the digital tools they developed for COVID-19 to support the influenza surveillance program. So that integration is happening at country level. So I think it's important that we push, that type of initiatives at country level. Thank you again. This has been really, very, very helpful. So I would like to give the floor now to Dr. Amadou Guel, the Acting Director General of Africa CDC, to give his opening remarks. Thank you.
Thank you, Ienu, and good afternoon, colleagues. It's really good to have this topic being discussed, particularly now that we are sort of in the tail end of the acute phase of the pandemic, which was very disruptive, and now we are slowly coming back to, I don't want to say normal, but at least we are slowly coming back together. And Andrea, thank you very much for making it to this second edition of the Conference for Public Health in Africa. We are looking forward as Africa CDC to even closer partnership and working relation. I would also like to thank the partners that we work with in the digitalization space. There are almost all of them here: US CDC, European CDC, Health Information System, South Africa. I see AMREF, the University of Gonda, the Commission. We are mostly here, so thank you very much for coming together for this very important piece of work. Let me take you back a little to memories that sometimes you want to forget, and that's the lockdowns. The lockdowns and the curfews, zero movement. The difficulties of that time gave us an opportunity to start thinking, how else can we be able to engage? And I think it provided a very strong basis for digitalizing a lot of what we used to take for granted, a lot of what we used to do physically. So this is all going digital now. And during those lockdowns, you recall how everything was a webinar. We will be in 17 webinars in 1 hour. And sometimes with multiple gadgets, and how we survived, I don't know, but somehow we did. and we are here today. But also we did a lot of training online, a lot of training. I think, I can't remember how many hundreds of trainings we did Yenu on all the platforms. It was a lot of training, and the numbers were very impressive. We would never have done that if it was physical. The sheer cost would have been prohibitive, and even the time for us to be able to move around would have been very difficult. So there are very positive steps that came out of the lockdowns and the curfews, the difficulties of meeting together, and if that has led us to where we are today, I think it is not entirely a very bad thing. The only problem is Africa CDC, we don't know what lockdowns are. We used to hear people are going on lockdown, but we worked throughout. I don't know what lockdown is, so we will still be able to find ourselves in the office to coordinate the response around the continent. But this is an opportunity for us to be able to do things differently. And at Africa CDC, we've taken it very seriously, and we have begun the journey of ensuring that digitalization is part of not just the lessons learned, but the opportunities that we are turning into actual action. And I'll share 3 of those. One is we've developed a policy and standard for digital health system on the continent. We are looking at health information exchange in a different way. You know, before it used to be an idea and it was good, but now it is almost an imperative when you look at certain areas of our work. If you want speed, and a good example here, if you want speed, you have to go digital. You just have to ensure that you go digital. We had the opportunity of signing an agreement with Smart Africa, which is based here in the sidelines of the UN General Assembly. And the president of Malawi was saying that, you know, let's not just sign the MOU, let's implement it. And he offered his country as a first place to go. What I have asked the head of the digital area of work is, how can we ensure that within hours, we at Africa CDC can know that there has been an outbreak in the northwestern part of country Y, so that we cut it down from knowing in days or weeks to knowing in hours. And I'm talking Africa CDC. I'm not talking about the national level. So the national level should know it even faster. And it is possible. And we are now exploring, implementing the policy in terms of getting our community health workers to have little digital tools that can be able to send that information quickly. That way, if there is a cholera case here and another one over there and another on the other side, the center that brings all this information together will be able to know within minutes of whatever information being sent. Someone can be sent to go and confirm, and immediately we know, and we can be able to prepare. As Africa CDC, our ambition is that within 48 hours maximum, or 48 hours, we'll be able to respond to any public health event which is significant in as far as a rapid spread is concerned. So this is where we are going by putting in place the health information exchange policy and standard. Secondly, is we have developed an electronic tool to support the capture, the analysis, and a retrieval of public health data. You will recall, those of us who've worked in Africa for a while, the data is all on paper. And someone is asked at the end of the day, at the end of the week, at the end of the month, very often at the end of the quarter, to put it all together. And it is painstaking work. You count malaria cases, you count, and then all this goes to the center maybe 6 months later. Now, if you're in a health emergency response, getting the information next week is already late. Now, getting it 6 months later is actually not useful. So this electronic tool, we are implementing it progressively across different member states on the continent, and we want to see how fast, if we digitalize, can we be able to get actionable data that has been analyzed. Now, we are not talking about emergency data. We are talking about data that has been collected, we analyze it, and then we use it for action in terms of resource reallocation and partnering depending on which type of illness we may be able to see in the community. Third, and this has already been touched on, is we are doing a continental digital transformation strategy. And there is another track that is going on this strategy. We want to reach a space where our data from public health can be able to easily interact with data from elsewhere. Climate change, agriculture, the animal world, etc., etc., even the political world. How do we bring it all together so that utilizing artificial intelligence, we can start doing good prediction, the modeling you're talking about, but good modeling this time, based on real data that is coming from very many different sources. As colleagues in public health, we don't have access to all that data. But then when we have the strategy in place, then we can be able to pool the data. And the Africa Union Commission, actually, is also just finalizing its own strategy, which is a little bit different from what we are doing. It's broader. So we want to see how these two strategies can be able to speak together so that we truly have digitalized the whole space that affects public health. And in this way, we can be able to have much better information for planning and also for response. But, and as Andrea was pointing out, there are challenges with all this. Where will the resources come? Now, first of all, even before the resources, will our policymakers understand it? And that is why one ask that I have of this session today is let's come up with those recommendations that we can be able to take to our policymakers. But please, let's make them simple. You know, our politicians they are there for 4 or 5 years. If you're in certain countries, it may go up to 7, but usually it is 3 to 4 years. So let's get messages that are within that time frame. Let's not talk of these a 20-year strategy, you've lost them, and they're not going to want to invest. But we may have a 20-year vision. Let's break it down into 5, and it becomes 4 years, 4 years, 4 years. Then we can be able to sell that. So let's have something that we can be able to sell to the politicians. So when those resources become, inaccessible, it means that we are not communicating. That's the way I want to look at it. I don't want to take responsibility when they refuse us resources, but if we are communicating well, I think the resources are actually going to come. Then the sheer need of infrastructure that we need to put together around the continent, from the simple things like these mobile phones that are in every village, to the more complex data centers that we need for analysis and coming up with good policy briefs. We need to look at those disparities. How do we move in a way that we don't leave too many behind? We need to find a balance where we are not holding back those who are ahead, but we are also not leaving behind those who may be a little bit slow. So that bridging that gap is going to be extremely, extremely important. So I'm really hoping that as we discuss, let us also identify those low-hanging fruits, something we can do, even with the little resources that we have. What can we be able to do now that is going to give us the confidence that we can deliver, that is also going to act as motivation for our policymakers to put a little bit more into the resource packet. But personally for me, money is number 3. Number 1 will always be our confidence that we can do it. Number 2 will be we harness the human capacity that we already have. And the private sector has a lot of that. How do we convince them to come on board early and we utilize whatever they already have and probably they're not using to full capacity? How do we bring that together so that they are able to contribute in a very productive way? And all this covers what we now call our new public health order, and partnership is a very strong part of that. So I'm looking forward to your discussions, your recommendations, and then we see how best as Africa CDC we can be able to do some early implementation. Thank you.
Great. That's really excellent vision. Putting together all components that we need to address. I really picked one important thing, which is starting with small, demonstrates that this is doable, demonstrates that this is impactful, and then that leads into a larger program. And any program, especially the program that we are starting, it requires a political commitment, financial resource, and then following the right process and procedures, putting the right tools together. Thank you, Dr. Ahmed, for your big vision in terms of digital transformation. And then this will be part of that big umbrella. And especially, using digitalization of our data collection tools, linking epidemiology and laboratory data, and then putting that one on a map, and that you trace any change over the trend of any health event, and then you identify the outbreak early, epidemic intelligence. So we know prevention is much cheaper as compared to a response in terms of dealing with the outbreak. We have seen even in COVID that the response has been in billions. But we haven't really spent in millions in terms of preparing our early warning and epidemic intelligence systems. So digitalization is also calling into investing in such type of systems where we can identify health events early before they become out of hand, out of control. So thank you again. So this has been a very exciting session. Thank you both, Director Generals. I would like you to join the audience. Thank you. Yeah, okay. So before I hand over my power here to our colleague Tom. So let me thank the Africa CDC team and partners who have been putting this working very hard to put this side event together. So I would like to thank Mercy, Moses, Bakura, and other Africa CDC team, and also partners who helped us, in putting this important side event. So I would like now to call upon my old friend Tom. We used to work, in the same space on PEPFAR HI programming. So it's good to reconnect back. So I will hand over the floor to you. Thank you.
Thank you so much. Thank you so much, Dr. Yenu. As you mentioned, we are old friends. We worked together for the US CDC before he ran away to work closer with the continent, with Africa CDC. So, good afternoon, everyone. It's really good to see you all here. My name is Tom Oluoch. I work for the US CDC. That's my day job. Also, besides that, I'm a past president of HELINA. HELINA is the Health Informatics in Africa, which is a Pan-African association that promotes largely health information or informatics research, and also education and capacity building. So we've worked very closely with Africa CDC through my role in Helena, but also through my role at the US CDC. So Africa CDC are very good friends in all directions. So without taking too much time, I'm going to introduce our speakers for this very interesting sessions. So the way we're going to run it is we're going to have presentations. The first one is going to be by Mercy King, and she's going to be telling us about leveraging digital technology for early detection and reporting of public health threats. So once she's done with her presentation, we'll have like a minute or two for any quick burning questions, and then we'll move on to the next presenter. So with that, let me invite Mercy over.
Thank you so much, Tom. Good afternoon, everyone. I'm sorry that we have a kind of a small room, but just imagine yourself in a very, very vast space and just enjoy this environment. So I'm just going to be presenting to you on the use of digital solutions to improve early detection, and we're going to be talking about the Africa CDC's experience. So I just want you to imagine someone who dies in a country, say country A, and then had two contacts who took him to the burial ground. And maybe in a few days, one of the contacts becomes symptomatic, but decides to, say, place himself on maybe an antipyretic and release himself of the symptoms, and had a travel to make, goes through the point of entry, through the thermal scanners undetected, finds himself in country B. So I'm just trying to make us reflect around how, as situations are evolving, pandemics are evolving, the human being is also evolving, looking at different ways of evading some of these detection mechanisms. So without a functional epidemic intelligence community, looking at it from the cross-border perspective, this case would definitely not be captured promptly in country B, because he or she has gone through the thermal scanner undetected. So here, what is the missing link? As Africa CDC, we realize that it takes beyond just technology to be able to detect. It takes both epidemic intelligence and also a community of trained individuals to be able to detect diseases promptly. And so we have an approach that we'll be able to institutionalize, to be able to bridge this gap that I've just identified. So as Africa CDC, we have a regional network of surveillance experts that we have been able to train. And these regional experts are from the member states. They have been trained on epidemic intelligence. They have been trained on event-based surveillance. And we have been able to utilize, using our convening power as the African Union, to bring them together through using a regional approach into a community of practice. We also have a digital platform for health information exchange. As of now, we are mainly relying on the epidemic intelligence from open source community initiative. That is also part of the detection. It has the detection and reporting component, and also the ability for different teams to be able to share information. We've also utilized WhatsApp groups to be able to put these countries together to share information. Of course, these are baby steps that we are making towards pulling them into a very bigger, more structured digital environment. Again, we have an epidemic intelligence system for detection, which is the EIS that I just mentioned, the epidemic intelligence for open sources. And we are also using different open source solutions like the AP Twitter that was just recently developed. We are also using the different social media platforms for detection. And also, we have also developed an event management system. I know these are all scattered resources or initiatives, but I want us to just reflect on how we put this together towards addressing the gap we just identified in the first slide. So we have the Epidemic Intelligence Regional Community that use epidemic intelligence methods to detect. Some of these countries already have the EIOS, that's epidemic intelligence from open source platforms, that they detect and are able to pull in information into some of these health information exchange platforms that we've developed. And within this community, we have the member state focal points that are able to go into these communities and pull out information that are relevant to their early warning systems. We also have the event management system that we are supporting countries to have. We've supported 4 member states now who are currently piloting the system. And once they process this information that they detect from these communities, they are able now to log them into this system and then manage them through to response. Next slide. And again, of course, we have the feedback mechanism. But the feedback mechanism is a little bit tricky here because some countries that have not institutionalized, maybe say data sharing agreement, might not be able to go back to the countries that flag this information to say, hey, this is what we found at the end. This is a laboratory confirmation. And I think that's one of the gaps that maybe we'll be looking at subsequently. So the Africa CDC event management system has really supported us internally to be able to detect over 300 events, 17% of which are animal events, 77% are from the human health sector, and 6% are from the environmental sector. And we've been able to detect all this from 47 member states. So out of that, this is our support package. This is what we're doing. Like I said, if you build up a very robust digital solution without the human capital taken into consideration, it's going to be lying there dormant. So we are also considering the other areas that have a very strong bearing towards ensuring that the digital solutions are being utilized, and we are able to integrate the epidemic intelligence that we're all looking out for. So we are developing guidelines, we are building capacity for member states and regional economic communities, we are establishing technical working groups, and also community of practices. So basically now what we have 3 community of practices that we've been able to set up in the northern, the central, and in the southern AU regions. And these communities of practice are actually supporting the detection and reporting of public health threats on the continent. As you can see, we've trained over 700 surveillance officers from across the different sectors, human, animal, and environment. And 14 countries so far have been supported, but we're still counting. Most interestingly, that has to do with what we're talking about today, is the development and the deployment of the event management system, which we are currently being able to integrate with other open sources. Like the EIOS, we are now able to detect from the EIOS and stream the data directly into the event management system. And this is what we've been able to do for the 4 countries that we've supported so far. I think the director of Africa CDC, Dr. Ahmed, and Dr. Andreas actually have highlighted some of the gaps. I don't think I should repeat, but again, this influx of digital solution is actually a problem because we have so many fragmented systems, and some of which have proprietary rights and are not able to, they are not able to be customized, or they are not able to interoperate with other existing solutions. We also have wide disparity on capacity, because we know that the continent, of course, is not homogeneous. Different countries are at different levels. Even within the same country, we still have that disparity in capacity. And this could just be because of other factors that maybe are not totally in the hands of the public health sector. For instance, access to internet, access to maybe the digital solutions, and those are things that maybe are very difficult for the human health to really make a direct impact on. Another thing, again, could just be the lack of harmonized standards. I'll give you an example, just the unique identifiers. If we don't have it in the country, it's really very difficult to really create that linkage with systems and really be able to pull data for a particular person from different systems. So those are some of the things that has to do with very high level of policy advocacy that maybe might not really be in the hands of just the public health sector again. Lack of trust on digital solutions, sensitivity with data and information. The cost factor is something that I think Dr. Andreas really pulled out on it very strongly, which is also very important. If you go to countries, you see that there are so many solutions, but most of these solutions are lying at the national level. They have not been able to be rolled out to the different lower levels that do need them, because the cost, the funding is really not there. So way forward, of course, we have learned about the solutions. We've seen where the gaps are, but again, there are always solutions to them. And some of these solutions will need short-term, can be handled short-term wise, but others would need maybe a longer duration for us to be able to get it done. But leadership and coordination, these are just low-hanging fruits that can be done. When we're talking about leadership and coordination or collaboration and partnership, we are talking about bringing the different stakeholders that are very relevant to digitalization. And this not only includes the partners, but how does this, how can we engage even the civil society? How can we engage the civilians to be also part of this? How can we engage the population to be also part of this? An example is Africa. We have over 70% of our population young people, people below the age of 40. And these are the people who actually have strong interest in digitalization. How do we ensure that they are part of the system, they are part of the workforce towards fostering this agenda? So when we are looking at about collaboration and partnership, it's not only about partners and other, but we're also looking at engaging the people and also ensuring that they own the process. Capacity building and support. It's very key. There are certain key capacities or key competencies that are really missing on the continent. Or if we have them, it's really not well spread out. For instance, health informaticians. There are really very few of them. And those that even have an understanding on maybe public health. So it's really difficult for them now to really flow within the public health system and support in pushing forward this agenda. Research, data analytics, data availability, access, and use. For us to be able to showcase that this is really valuable, policymakers want to see the cost benefit. They want to see what is in there for them. And they don't, if you tell them about people dying, it might really not sound well. But if you're telling them about this is the workforce that would have delivered this amount of money, it makes sense that we don't have because they died, the data was not accurate for us to be able to have managed them. Or this is, so we need to get to a point where we are able to generate evidence to show the value digitalization brings forth. And this is something that's really missing. We are all clamoring for digitalization, but we definitely need to get into research. We need to develop evidence and be able to showcase its added value. So thank you so much. This is the end of my presentation. I was given 10 minutes, and I hope that we all learn from this. Alexander Bell would say is that great discoveries and improvements invariably involve the cooperation of many minds. I mean, this is really very interesting because, you definitely need everyone. You need the minds of the young people, especially harnessing on the demographic dividends on the continent to be able to pull that great resource that we have and get them also engaged in the digitalization process. So thank you so much.
Thank you. Thank you, Mercy. Thank you so much. So yeah, that's a great presentation on just where we are, what the next steps are, and I think you've highlighted some very, very important aspects. So we just have like a minute or two for one or two quick questions, if anybody has. Yes, please, go ahead.
Firstly, thank you very much for the presentation and the insight into the digital platforms. Excuse me. My question is, I'm sure you would agree that the digital platforms are as good as the data that's pulling through and the underlying information. What challenges have you had in obtaining the data, especially last mile patient data? And what solutions do you have to overcome those challenges?
Hello, my name is Osvaldo, come from Mozambique, National Institute of Health. In this same line, in your opinion, what kind of problems we have, ethical problems, with the digital information when we talk about the patients or community level?
most likely going to be a recommendation or a remark. The efforts of African CDC in identifying programs or projects that are into this space, because there are a lot of projects going on all over Africa, especially digitalization projects. What has African Union done as effort to bring together the partners and government partners, non-government partners that are involved in this space, and to leverage on that so that we move in the same direction? Because from all the presentation, we want to really move in the same direction, but it seems that we don't have visibility on all those efforts that are being done throughout the continent. Thank you.
Thank you so much. They are all very good questions and also tough. And I also see Dr. Justin, Dr. Yenu, feel free to jump in when you think there is need. So starting with the first question around improving data quality. This is a big issue everywhere, like almost everywhere we have that. And there are so many factors that influence data quality. It starts even from the very beginning of developing the tool. If a tool is not user-friendly, definitely you will not have maybe the users being able to populate all the different fields or the elements that you are giving them. So they have to be engaged in the process of understanding and developing that tool. That's one of the issues that this is actually out of experience supporting a country, where we went there and actually assessed the tool, spoke with the different stakeholders that are in charge of populating the tool or utilizing these digital solutions. And one of the things is, I don't have that time to fill all this. So, and that tool, if you don't have maybe some of the rules to ensure that some of them are mandatory or they're auto-populated, or you have those quality rules that you can embed in these tools to help guide how this data is entered, you definitely will not have. That's one. The second could be just the issue of the competent workforce. If you look at our lowest level where data is being captured at the facility, most of these people capturing data are not data managers. They are nurses that are being turned to data managers, and because there is no human resource, they have to do that. Or you get to the facility where you have maybe a district. Maybe this is a surveillance officer that maybe has no idea, or it's a nurse, by the way. Most of those people that we call surveillance officers have not even gone through training, like real training on data management and all that. So you have those happening there. So another issue is the workforce, competent workforce, that is a problem. And the third issue is the lack of standards. If you have to maybe aggregate or maybe integrate data from different levels, you definitely need to have everyone understanding the standards on how these are collected, or you have to institutionalize standards on how this data is collected. If A is just nomenclature, if A calls, or the vocabulary, if A calls something different from B, you definitely will not be able to pull this data together and make meaningful decisions from that. So it becomes a whole issue. So I think those are really very key issues that needs to be looked into. The capacity building, that's the lack of human resource, the issue about the lack of engagement of the users from the onset. So you develop a tool that is not accepted by users, and at the end of the day, they end up not using the tool appropriately. So another thing could be that, the standards are not there, so you are not able to integrate. So I think those are very, and finally at the end of the day, you have different data with just all messed up. So those are some of the things that I can be able to highlight, but I leave it to my colleagues who can add more to that. The second around community level data, if I got you right, you were asking about the challenges at the community in, especially those that are capturing data at the lowest level of the community. Is that right? Yes, ethical issues. Again, that's also very important. So that is one of the things that we're trying to solve as Africa CDC, where we came up with the Health Information Exchange Policy and Standards. So the document looked into those different considerations that countries should take. For instance, the security, the ethical considerations. It also looked at, the standard on the device-to-device exchange. So if you have two devices, maybe community and the health and the district trying to exchange information, what are those standards that have to be in place for those two devices to ensure that this patient data is secured? And patient consent is also another issue around patient health records, medical records. So those are things that are taken into consideration around that space when patients have to be engaged in data collection. So that is really being institutionalized at the very higher level, national level, where they have all those policies on patient data security and all that. But at the community level where we are dealing with health security, some of those are waived, where you have to get information that has to do with maybe, that has the country security at stake. Those, even the HIPAA for the US, they actually have waived some of those. It's mandatory. But if it's something that has to do with medical situation, just getting to assess the patient, of course, those different measures for most countries that we have worked with, they have put those standards, and that has to do with policy. And that's why if you look at the health information exchange policy and standard that we developed, we realized that you cannot institutionalize the standards if you don't have the enabling policies for that. So that has to do with like the data governance and all that. So it's actually from the higher level that, so the community people cannot really make those decisions. The higher level takes those policies that can support the data collections at those lower levels. So it's mainly the policy issue. Bringing together partners. The health information exchange is a demonstration of Africa CDC's partnership. So we actually brought together partners to do this. We know that so many different initiatives going on, and this is where the digital transformation strategy comes into play. So the Africa CDC is actually driving the Africa digital transformation strategy, where we want to come up with a strategy of the digitalization of public health systems. And how we are doing this is we started with a consultative meeting just internally, and we went broadly to bring in other partners that are supporting digitalization on the continent. And these partners, brought up different initiatives that are currently being implemented. So it was really a very comprehensive approach to the development, and it's still ongoing. So it's a lot. We took into account a lot around stakeholder involvement, consultative meetings to get to understand what is on the continent, just so that we can be able to work together towards the development of this strategy. So we are not working in silos. It's definitely a collaborative approach. So yeah, I think those are the three key questions.
Yeah, thank you so much, Mercy. So I think because of time, we have to move on. I know other senior colleagues like Dr. Justin are there, but maybe they can talk right at the end, because we have a Q&A session for for all the presentations at the end. So if there's anything else to add, please, that would be a good opportunity to add. So thank you, Mercy. Okay, so we'll move on to the next presentation, and that's going to be establishing standards and policies to scale up digitalization of public health systems. And this is going to be a joint presentation between HISP South Africa and the University of Rwanda. And the two presenters are going to be Dr. Ahmed from HISP Africa and Dr. Binyam from the University of Rwanda. So welcome.
Good afternoon, everyone. So I am presenting Moses, the slides. So my name is Binyam. I work at the University of Rwanda. I am an associate professor and also leading the Center of Excellence for Digital Health at the University of Rwanda. And then here with me, we have Dr. Ahmed. Can you show us your hand? He is also the program manager at HISP. So both of us have been providing technical support for Africa CDC for the development of AUHI policy and also standards for digital health work. So I think I will be sharing this briefly. I think in this work, the main one was we're providing the technical support, but we're having also the task force members and also the Africa CDC colleagues. So on behalf of them, I will be sharing the results. So as you can see, like a lot was being said about digital health in Africa. As you can see, we have different digital health systems in African setting. It can be in the clinical setting or in the public health setting. Like there are different digital health systems which are being in place in the continent. Next. So if you go to at the member state level, there are also different level of digital health implementations, like a massive progress for the last 10 years especially. Like if you start from the community at the primary care level, to the hospitals, to the written reporting, and also to the national level, there are different systems which are being used. I just mentioned here as an example, like OpenMR, SDHIS2, because they are global goods. But if you see overall the continent, there are so many systems which are being placed. But if we see especially the one I highlighted at the national level, the level of analyzing that data and then using it for decision making has been very minimal at the member state level. Next. So what are the challenges? I think Mercy was highlighting, like the main challenge is we are having different systems, and also we don't have really regulatory mechanism on the how data is reported and then how we are going to use them. And also the sensitivity of information that is very, very, very sensitive, like health information. Whenever you take like one politician and then if you say, oh, I'm having a systematic cloud, like I experienced it so many times, they say no. So like that sensitivity, it's important, but we are very sensitive for it. And then the other one is, like as we see, like we don't have really endorsed standards at the continental level, as well as the level of capacity we are having to deploy those is the main challenge. I think they were also being highlighted previously. So to do this, I think like at the national level, there are so many initiatives. And then how we can do that at the continental level is very important. And then I think Dr. Ahmed was also highlighting how we can pull all that data from the continent and then getting that continental level insight as well as continental level decision making is very important. Next, Mos. So for this, I think as you know, like in 2017, Africa CDC has this strategic pillar for Africa CDC. And then among them was information systems, like to achieve this, the pandemic, and then for all the response, information systems, and then having that capacity has been one of the major approach. And also from the digital transformation, which was being mentioned by Dr. Yeneo and then the other colleagues previously, which is being also, I think, discussed concurrently with this session. I think for the next years, there will be a lot in digital transformation working overall on the continent or also within Africa CDC. So with all this vision, next. With all this vision, the main thing, the work we did is that, like as I said previously, we have the digital health systems in the continent. I think we are having that. And then the idea is how we can have a digital health policy and the standards in place as an additional layer. And then if we can have a policy, how data can be reported, what kind of data elements, in what kind of standard. For example, some countries use, for example, for communication protocol, HL7 protocol. The others use different protocol. So the idea is if we can have that consistent standard and then consistent policy as an additional layer, and then on top of that, if we can have a data sharing agreement which is signed between member states and then Africa CDC, the vision is within Africa CDC, we can create a big data analytics platform that can be used for the continent for decision making. And then decision makers at the continent level, if they really want to know how is malaria overall the continent, it should be a click away, right? So that is with that vision. I think in this document, we have been working, what are the levels of the standards needed, what are the policies needed, which needs to be in place in this. So in the document is a bit long, so I will highlightly show you what are the main contents and then what were the major approaches. Next. So I think the work was started in 2020 during almost COVID time. And then the composition was, we're having around 32 task force members. So those task force members were the ones who are guiding all this development, all the support, all their idea. And then the main objective is, as I said previously, to develop the HI policy and then the standards for digital health, which can be approved and used by all member states in the African continent. So the output is that for the last 1 year, we have been like validating it throughout Africa. Like we had like 5 validations in the north, in the west, in the east, in the south, in the central region. All the member states represented by their expertise, we have that validation. And then currently, as you can see from the right-hand side, that is the document we're having. Now it is being, this is a validation pictures. Even during COVID time, we're doing those validations. And then this document is now on final copy edit, which should be like on the final approval, and then which should be shared for the digital health community on the Africa CDC website very soon. So going to the major contents, next. Going to the major contents. The major approach we're having is that the first thing we do is we do the review of evidence, like what's happening within like health information exchange, and then what kind of standards. Whenever we say standards, actually, we are not supposed to create like a new standard, right? Like if we are saying standards, we need to adapt what is experienced at the global level. So that's what we did. And then in terms of policy, I think that was a part which needs a lot of discussion, because if we say like member states will be reporting some data in 7 days, then like how we can bring that date and then having that consensus of dates, those kind of discussions has been happening among the task force members. So we do the review of the evidence, we do a review of like what are the internationally known standards that can be taken by the continent. And also we added also the suggestion of those task force members, the 32 members, which are very high level experts in their field of study. Next, Moss. So on the review of the current evidence base and then what we have, I think the team, we review it, and then this paper is already published. If you are interested about this topic, a very interesting topic to read about, we have a paper on PLOS Digital Health. If you like search it with the title Health Information Exchange Policy Standards for Digital Health Systems in Africa, it's a review paper. You can find it online, which is being used as an evidence. Next, Moss. Can you say next? Moses, don't leave the computer. I don't have the next button. So in terms of the policy, I will highlightly tell you. So the major recommendation areas, if you go through the document, the first one is on the policy section. We highlighted what kind of governance we need. I mean, like at the continent level, when we are having data, we are reporting that data. So what kind of governance framework is needed? What kind of legal framework is needed? And then what kinds of governance body is needed to be established within the continent at Africa CDC, as well as at the member state level. And then the second section is what kind of the continental data exchange, the architecture, the reporting, and then the data sharing. As I said previously, what kind of report is needed, and then the frequency, and then how we can do it. That is highlighted in this section. And then the third one is data ownership and then use agreements. Definitely, whenever we have the member states data, the data is like owned by member states. And then the major important thing is how Africa CDC can use that data. Like, will it be individual data? Most of the times, the recommendation is having aggregated data, and then that aggregated data can be analyzed and then used for decision making. Previously, someone was asking also about the community data and how much sensitive it is. It's known that it's sensitive, but like what level of detail and then what kind of data we can share is highlighted in this document. And then the fifth section, I think the first section is open data. As we know, like whenever we have a very free data that can be used by anyone, that can be labeled as open data. And then what kind of data can be open data? Like here, really, there is no individual data, even at aggregate level. Going on top, what level kind of data is open data? That's also highlighted in this section. And then the last section in the policy section is the data privacy and then security policies. Whenever there is any data breach or if there is any privacy concerns, what kind of process need to be in place among member states as well as at the continent level? It is highlighted in this part. So moving forward to the standards is, as I said previously, we didn't reinvent standards. Somehow we take the globally golden standards, which are recommended at global level. We just adopt them for the continent. So the major sections in this part, in this recommendation area, is that The first one is standards for messaging protocol, like what kind of messaging protocol we can use. As you say, like most of the times now, like in the world we are using HL7 protocol, so we are recommending that. And also, as you know, the FIRE standard, FIRE is on fire, someone was saying last week that. So like we are also recommending the FIRE standard. And then the other one is, next most. The other one is for the privacy and security. We also adopted those standard processes. And then the third one is for, next most, common foundation standards like standard management and messaging exchange, and then protocol, and then service for interoperability. Those are the standards which we just adopted from the global standards. And then the last section is the implementation framework. So in terms of implementation framework, we just highlighted, like we have now the policy, we have now the standard. Now how we can implement that on the continent, what is needed, that is highlighted in this area. So 5 areas actually are highlighted on the implementation section. The first one is how we can do infrastructure development, like how we can support, how member states can do that, and then how Africa CDC can do that. And then here, as Dr. Ahmed was saying, infrastructure should not be the first. It should be the third priority, he was saying, but that is one of the support area which is needed because basic services are needed for this. And then the other one is the investment, the mentoring and evaluation, the research, and then the capacity building. These are the 5 areas which are highlighted in the document. So in terms of capacity building, I think one of the things we highlighted, next slide, Moses, was the team recommended to have a public health informatics fellowship program, how we can have that fellowship program, so that at the continent level, we can train people, we can attach them on member states, and then we can have it like a 1-year, 2-year internship program, so that we can have that certified program. We have this kind of program within US CDC, how we can adapt that and then implement in Africa setting. That was also another recommendation. And then also we can do that in collaboration with universities, and also like continental bodies like Helena and then the others. Next. So the task force members, this was a statement which we're saying it, like in this document, we really envision as a conclusion, we really envision the HI policy will standardize digital health journey of the continent where everyone in the continent can benefit fully and immediately from digital health investments. So thank you so much. Those are the partners. And then the next slide is I really want to acknowledge the task force members. I think it's not readable, but those are the 32 task force members who contributed a lot. There are some members, including Tom and the task force. I want to say thank you so much for all that contribution. Thank you. That's my final slide. Thank you so much.
Thank you so much, Binyam. Very good presentation and very clear highlights of what the standards and policy document include. So just because of time, we'll take 2 or 3 very quick questions, and we'll request you, Binyam, to be very precise when you respond, if there are any. Any questions on the standards, policy and standards document for health information exchange for Africa? Okay. Dr. Justin, welcome. I'm sure you probably want to add something.
So thank you, and because I'm just rushing to another meeting, I said let me just have a quick say about the HIA policy and standard before I leave. And I think I remember back then when this whole process started, it was very ambitious, and there are certain things that were motivating the whole process. And one of the things was to make sure, I think, we're trying to look on the brighter side of this than the challenges that have been discussed about how do we get the quality data that inform decision in the continent and allow people to share the data. And we're thinking around things that on how do we make data availability, access, and use at all levels of implementation, from the community to the regional and continental, or even in the global level, around availability of quality data, use of data from all levels, and also being able to access those data. And we envision a world whereby one day in Africa will reach a time that having your data being accessible even to to other levels that are required for implementation should be an incentive, and everyone will be striving that let me make my data being accessible than trying to push people to report into that. And that way, it had to work through all this. And there are several things that has to be put in place to allow that environment. And one of the things is to incentivize the whole process of data sharing. And the sharing and access is different. That we are assuming that sharing is when you have the data and you have to share. And access is whereby you feel like if I have the data that is in here and I'm collecting it through standardized tools and it's somewhere where it can be accessible, I should allow accessibility, because the accessibility has to be also incentivized. And the incentive that comes there is about adding a value into what they're giving you an access. So if people are giving you an access to data, it should bounce back with some added value to it, either in terms of response, timely response, in terms of an advice that guides them on what to do next, or guiding their decision at the local level, at the community level, and where it needed the most. And that is the whole process. But for that to happen, I think these standards, policies have to be there. If you allow access, means the system that will be accessing the data or exchanging the data should be interoperable, should be in a way that they trust that if I give you an access to my system, the security from your side and the security from my side for the data security, they are aligned, and there's no any risk of exposing my data to people who may misuse that data. So all these are the incentives that are being created around. And I think it's a long journey. We're not going to reach there, but we should be optimistic that one day this will be achieved within the continent. And I think the whole process of inviting creative mind, innovations, and the thinking, a critical thinking going into it to make sure that one day that big vision, that ambitious vision of the continent on that will be achieved. So I just wanted to let it that, so we should not be discouraged by the challenges, but we should see the opportunities that we really need to invest on this, because there is a value to invest on it. Thank you.
Great, yeah. Yeah, thank you so much, Dr. Justin, for taking us back to the history. Actually, he was there from the beginning when the process started. So yeah, and also provided great leadership to all the members of the task force that Dr. Bijam mentioned. So thank you so much, and we really appreciate the history and the vision moving forward.
So I think like Justin was just supplementing. I don't have anything to answer, but Justin from the starting, he was the one who was also providing all the support with Africa CDC colleagues, and also he was pushing for this work. I really want to say thank you for that with everyone from Africa CDC, and also for complementing that work. So thank you so much, Justin.
Thank you. Thanks a lot. So I think with that, I'll invite Julian to take over.
Thank you, Tom. Good afternoon, everybody. My name is Julien Bottet. I am a medical epidemiologist working at the European CDC, and it's a great pleasure to be here with you today with the Africa CDC colleagues and others. So the next talk will be given by my colleague Gianfranco Spiteri on the opportunities, but also many challenges we faced during the COVID-19 pandemic. Just before we start, I would like to highlight the importance of collaboration, exchange of experiences when it comes to digital health. I mean, we have, well, there is many examples of what we call leapfrogging. So, you know, wherever the time when you start, there is possibility to bypass many of the intermediate steps that others take. I mean, mobile phone is a classical example, like in countries that went directly to a massive diffusion of mobile phone without the landline phase. It's also in terms of industry, what they call the advantage of the late movers. So, you know, looking at the errors that other makes, we can learn a lot and maybe avoid certain pitfalls. So, please, Gianfranco.
Thank you, Julien, and thank you to Mercy, Moses, and colleagues for inviting me to the CPHIA and to present here. So Mercy asked me to talk about success stories about development and deployment of digital solutions in public health. But I took out the success stories from the presentation because I think we're actually in a process of learning. And I mean, we as you will see from the presentation, we started from what we had before the pandemic, which we thought was fit for purpose. Then the pandemic came, and of course, for all of us, changed the way we see data analytics and visualizations. So it's not a field where we can kind of rest on our laurels and stay in one place, but it's continuously evolving, and that's what I will try to show you. So next slide, please. Yeah, so I come from the European Centre for Disease Prevention and Control. It's based in Solna, Sweden, a suburb of Stockholm. And we're about 350 staff, and the organization was established in 2005. Next slide, please. Yes, and again. Yeah, so here you will see all the partners which we work with. So it's important, the European CDC is kind of quite similar to the Africa CDC in terms of the way we work with member states. So in terms of surveillance, epidemic intelligence, we work at supranational level, but then a lot of the work is done actually in the countries by member states themselves. So all the surveillance implementation, indicator-based data reporting, for example, that's done by the member states. And our role is to support the member states and the European Commission in providing the best available evidence, information, epidemic intelligence, and response options. Then, next slide, please. Yeah, so these are the three kind of pillars which I was asked to speak about. So real-time data analytics, data visualization, and digital solutions. And the way we see this at ECDC is that they all feed into epidemic intelligence process and the situation awareness about public health threats and outbreaks which we are monitoring. Next slide, please. So at ECDC, the epidemic intelligence process revolves around the daily roundtable. So this is a meeting which is held at 11:30 every morning, where we discuss the threats detected by our epidemic intelligence team, signals, threats, and events. And these signals might come from different sources. So they might come from indicator-based surveillance data, so the data reported by member states to ECDC, for example, from event-based surveillance, so we have platforms which I'll describe later for member states to report outbreaks, for example, which might have a relevance at European level. And also our media monitoring, which is where we use tools like EIOS, which Mercy mentioned, which is used in the African continent as well, for detecting signals from open sources. And during the roundtable, we then take decisions on what action ECDC needs to take. And this could be, for example, developing a rapid risk assessment, producing epidemiological updates on our website, and communicating further with our stakeholders. And we also use the roundtable to then publish daily and weekly communicable disease threat reports. So every day, maybe an hour after the roundtable, we publish a summary of the events we've discussed, and the few initial and then initial assessment of any events which we detect, to be able to provide our stakeholders with already very early and very rapid options for responding to the events we detect. Next slide, please. So to support this the epidemic intelligence process, then we have developed different tools to help us throughout the whole process. So for example, we have a system called EpiPulse, which I'll show you in the next couple of slides, which is basically a combination of different tools. So it's possible through EpiPulse, for example, for member states to report what's happening in their countries. So if there's an outbreak which is of relevant at European level, or even if they want to discuss an outbreak or an event, then they can report it there and discuss it with colleagues from other member states. We use it also as our event management tool, so we detect, if at ECDC we detect through our epidemic intelligence processes something from open sources, for example, a threat or a signal of an outbreak in some country, then we can post it there, share it with the countries, but also log our actions there. And we also use it then to produce our reports, so the same information which we share with member states then ends up in a report which we share with our stakeholders to provide them situation awareness on all the signals and events that we detect. And this tool is available both internally within the CDC and also to a restricted audience which are our national focal points in member states. And it has we started using this actively during the pandemic, and now it is a main tool for our collaboration with our colleagues in the European member states. We also have other tools which we have developed for visualizing the data which we collect and which we use in our roundtable and epidemic intelligence work. For example, we have the surveillance atlas of communicable diseases, where it's easy to select diseases and then look at time series, trends, distributions by risk groups, for example. And that allows us to analyze the data quickly and report it in a very rapid way. We have also produced a number of dashboards, and I'll show you a few later on, and also a number of different surveillance reports. And many of these had been already in place before the pandemic, but as you will see, we had to change quite a bit the way we share information during the pandemic. And yes, and those are a few of the tools we use, but I'll go into that later on. So next slide, please. This is the example of the surveillance atlas, which has been in place for many years. And as you can see, at a glance, you can see for a specific disease what the key indicators are. So we can see what the trends are, distribution, both at country level, by age group, for example, and by risk group. So this helps us with kind of analyzing the data quickly and showing this, feeding this back to the countries in a rapid way. Next slide, please. We have also a number of surveillance bulletins which we produce. This is another one which is quite long-standing, the Flu News Europe Bulletin, which we have developed with WHO, the European Regional Office of WHO. And here again, we summarize on a weekly basis the trends in flu and describe the current situation with regards to flu. So these tools worked very well pre-pandemic. Next slide, please. But then when COVID-19 came, we really had to change very rapidly. So for example, you would have thought that we could maybe have used the flu reporting, sentinel surveillance for COVID. But this kind of collapsed very quickly during the early months of the pandemic in Europe. So we had to develop specific surveillance for COVID in the European Union. And also tools to visualize the data, feedback to the countries, etc., within a matter of weeks, because this was kind of, as you all know, an emerging threat, and we needed to communicate rapidly. So here we couldn't use tools which we already have. So we found it difficult to rapidly modify, for example, the surveillance atlas, modify Flu News Europe, etc. So we decided to go for open source-based tools to address these issues, and we ended up using R-based applications. So for example, we produced our weekly COVID bulletins for a very long time, since the early days of the pandemic, and we still do actually, using R Markdown. And in collaboration with WHO Euro, we also use our Shiny applications to visualize dashboards on the data. And the advantage with this was that we could deploy very rapidly. We could also modify the outputs essentially on a weekly basis. So whenever something new came up, new variant, or I mean, initially we weren't talking about variants at all. So when we had to introduce this, we could do it very quickly in a matter of days almost. And this helps us feedback the information to the countries very quickly. And we also made sure that all the data which we received was fed back to the countries in an open data kind of approach. So we try to publish everything very quickly on our website, so that even if we weren't using some of the data ourselves on an immediate basis, then other researchers could work on this data and support it. Next slide, please. So this is an example of the type of information that we produce in our COVID bulletin, and which we still do. So it ranges from trends in cases at national level. We publish kind of indicators at national and European level. We look at sequencing data. We look at sequencing capacity, for example, in countries, and monitor this over time. And we also incorporate forecasts in our reports to be able to support countries and to and show what's happening kind of in the near future. Next slide, please. So I mentioned SARS-CoV-2 variants, and the issue of variants came up during the middle of the pandemic, and we partly addressed it through the COVID bulletin, but there was very strong interest from the European Commission, for example, and member states on showing data on variants in an easy to visualize way, where you could just kind of basically go to a website, see the data with very few clicks, and you don't have to scroll too much other information. And then we shifted to a different type of tool. So we used ArcGIS application, which is an out-of-the-box tool. But again, it's a type of tool where you could develop something like this in a matter of days. And then this allowed us to kind of keep our stakeholders happy and informed with the evolving situation. This was actually, this dashboard was then mentioned by the Commission in some of the legislation which was passed on monitoring of the pandemic. Next slide, please. And again, we used other tools. This is a click-based dashboard where we presented the data on COVID at European but also global level for our stakeholders. And with this tool then, which was more tricky to adapt, then this was one of the tools which we kept kind of more stable over a longer period of time. Next slide, please. One other area which we worked on during the pandemic and which was not a very strong area of work for ECDC pre-pandemic was around forecast and scenarios, and Andrea mentioned this in her opening speech. So we established the European COVID-19 Forecast Hub in March 2021, and this was basically a group of modeling teams from across Europe who developed their own models, and then this was a way of bringing all this information together and produce a model of models, basically, which was actually much more precise than what we would otherwise have produced from each individual models. And then again, this data was shared openly, partly incorporated in our weekly bulletins, but more data presented in the Forecast Hub website. And more recently, the Scenario Hub was also established, and this was looking more at specific scenarios and more long-term predictions of what the future for COVID could come up with. Next slide, please. Yeah, I mentioned EpiPulse, and I went through kind of the functionalities before. This is a tool which we started using during the pandemic and has become extremely important in communicating with member states and also for member states to communicate between each other. So for example, we've used it for monkeypox, and the first cases of monkeypox were actually reported within this system. It was discussion within EpiPulse between member states on some strange syndrome in Portugal, and this allowed for kind of discussion on what tests should be done, and eventually with monkeypox being detected and followed up. And now we have an increase in invasive group A streptococcal infections, for example, going on in many countries, in some countries in Europe, and this is the platform we're using to discuss and share information with member states on this event. There's already been a lot of development in EpiPulse, but we plan to expand even more with production of dashboards, which will allow our member states to visualize the events which we're monitoring on a real-time basis, and also link EpiPulse to tools like EIOS, so that we streamline the whole process of epidemic intelligence, situation awareness. Next slide, please. Yes, I also wanted to mention EpiTweeter, which Mercy mentioned earlier. This is another tool which we started developing before the pandemic, but has come to its own during the pandemic. And this is an open source tool which allows us to monitor trends in Twitter data by category and geography as well. So this helps. It's R-based, has an artificial intelligence component that helps us to detect events through monitoring Twitter in an almost automated way. And we're planning to expand this to other social media as well in the future, depending on the availability of data from the social media tools. It's free, open source, and you have the links in the slides if there's interest in using the tool, and we're happy to support. Next slide, please. Yes, so I mean, it's been a bit of a whirlwind tour, but I didn't want to take a lot of your time. But in kind of the COVID-19 pandemic has really been a catalyst in developing of tools at ECDC in terms of data visualization, data analytics, and communicating with our member states. In the last couple of months, the European Council and the Commission have approved the updated ECDC mandate, and now there's even more of a focus on strengthening epidemiological surveillance in the European Union, and also gives us more of a mandate to work on a global level terms of surveillance and epidemic intelligence. And this is where I think we need to work together with partners like Africa CDC in strengthening our roles and collaboration, as we have been doing in the last couple of years. There's also definitely a stronger role in our mandate on data analytics, and particularly in the implementation of artificial intelligence in our processes. And we have started, and in the next year, actually, we plan to publish to work on a framework contract to start implementing artificial intelligence in different tools in our epidemic intelligence processes. And we will try to make those accessible through open source developments, so this can be shared more widely. And the ECDC mandate, the new mandate, also focuses on communicating with stakeholders, including the public. And this is one area which we will strengthen in terms of our communication and outputs to make them more easily accessible. And their analytics and dashboards and visualizations, of course, have an important role. In terms of tools which we will use, I mean, we are kind of working mostly with open source tools. But we have seen in the pandemic that even out-of-the-box solutions sometimes have benefits in terms of flexibility and supporting the way we work. So we will keep an open mind, but always try to work towards things which can be shared with our colleagues in member states. And of course, the aim will always be for flexibility, being able to deploy rapidly, since we're deploying rapidly, it might not be immediately the perfect solution, but then to review and adapt in a continuous development cycle. So I think that's it from my side. Yes, so thank you. And thank you to our colleagues in ECDC as well.
Thank you very much, Gianfranco. There is time for maybe a couple of burning questions from the audience to Gianfranco. Yes, please, Hamad.
Yeah, thank you, John. I think, and congratulations on the excellent work on this development of the various tools. I just want to ask a question which is linked towards the Director of African CDC. Among all these your tools and dashboards, are there specific ones that are directed to the political class so that it will help them in actually decision making, so that tools that are very simple enough and presented in such a way that they can easily comprehend and also actually facilitate them in taking decisions? Do we have something like that? Thank you.
Yes and no, in a way. So, for example, we work in two ways with the policymakers. So, for example, during the COVID pandemic, we were producing a weekly output which called a policy brief, which went to the very high levels of the Commission. And then it was not directly linked to the EPIPALS tool or one specific tool, but we used the information which we obtained through EPIPALS and through different sources of information to feed into this policy brief. And then this was it was done, I remember, every week on a Thursday. We had a very tight process to collect information from many different stakeholders, but then distilling the key information with kind of summary bullet points at the top to make it very easy to read for the policymakers. So that's one way. We also work with the Commission, with the European Commission, through the tool, through the WRS tool, which is the early warning and response system, which is where European member states report directly to the Commission on threats and events. And what we have been discussing now is about a way of sharing information from the EPIPAL system, which is more where we interact directly with the member state colleagues, with the public health institutes, distilling the information there, which we call a situation awareness, and then publishing that in the EWRS system. So what we want to do is kind of distill the information, which will be our work. So the countries report, they say we have monkeypox in this country. These are the age groups affected. This is the risk these are the risk groups that we see. Then we pull all this information together. We summarize it for the member states, but then that summary information goes to the policymakers together with a couple of bullet points so that if they're in a hurry, they can only read these bullet points and understand at a glance, okay, there's an increase in monkeypox, these are the affected countries, and these are the risk groups, for example, and this is the response that is being taken. So we're approaching it in different ways. It's also a process of learning, so we kind of try to get feedback very regularly from the Commission on the political side to try to improve the process. It has been actually quite a nice kind of bilateral relationship during the pandemic and even now with different activities. Thank you.
Tom, yes.
Yeah, thank you so much. Very informative presentation. So you talked a lot about legislation and policies. I was wondering whether you've come across situations where either national policies or legislation are not well aligned with the European Union level, and how you deal with situations like that. Because I think we have specific examples here in Africa where sometimes, I mean, there's countries, for example, that their policies are very clear that they do not allow for release of individually identifiable information or individual level data to go beyond the boundaries. So things like that, I mean, it would be good to hear your experience.
Yes, so I think maybe an example is kind of the early days of the COVID-19 pandemic. And before my role as a group leader of the epidemic intelligence team, I was coordinating COVID surveillance in Europe, you know, from the start of it. And we rapidly set up indicator-based surveillance. So we asked countries to report data. We agreed with them kind of on indicators which we wanted to monitor. This was case-based data, so individual level data. And initially this went well when cases were few in number, but rapidly when there was a rapid increase, then countries struggled. And it was not because of policies, but they just weren't able to sustain the reporting to us. So that left us with a bit of a gap. And then in this situation, we used a different approach. It was maybe new for ECDC and went for web scraping. So we actually, many of these countries were publishing the data on their own website, maybe with slightly different definitions. That's a kind of completely different story, I guess. But we could access these data, which they published publicly, and at least have a bit of a situation awareness of what was happening in the countries. And in the end, and after a few weeks, then we agreed with them that this was the way that we were going to kind of collect the data for these countries and to analyze and publish. So this was one way. So we automatically took the data from their websites, kind of considered it as officially reported, and then analyzed it. Of course, we didn't have the detailed data then, which we had from other countries. So for the countries which were reporting directly to us, we could look at risks, for example, for COVID-19 by age groups, by gender, risk of hospitalization, ICU admission, etc. That we couldn't do that, but at least it gave us a bit of information. So we tried kind of, I mean, during the pandemic, it's in a way understandable, right? That not all countries, depending on the resources, will be able to kind of have the same level of public health workforce and capacity to respond in the same way. So we try to find ways of kind of bypassing these issues and still working with countries, but reusing things which they were already doing to facilitate this. So yeah, so I guess the answer is trying to be flexible and working with the countries directly to find solutions.
Yes, please. I mean, maybe your last one now, because I think for the sake of time, then we need to
yeah,
open to the panel
thank you
discussion.
so much. I think it's excellent presentation. I'm just asking, like, regarding to data storage. Actually, many countries have been debated where this data stored. Is it cloud or independent server, whatever. So issue of maintenance of data and data storage is very critical that we are debating in many countries have been, you know, to just ensure where this data should be stored. So what's your experience in terms of European Union regarding to that issue? Thank you.
Yes, and I think this is an area Julian is also an expert on. But with indicator-based data, we have a system called TESI, where European member states report directly through it, and this will be integrated in EPIPAS in the future. But we have, there's an agreement that data is stored at ECDC, and we have very strict rules on accessibility of data. Having said that, with some specific types of data, there have been some sensitivities with sharing of data with ECDC. Since ECDC is a European Union agency, we are bound with some rules of that some legislations around sharing of data and open availability of data. So some sensitive data some countries might not be willing to report if a journalist, for example, could ask for the data, and then we would have to release it. So for those situations, we have found some other solutions where the data are, for example, kept at member state level, and then ECDC accesses them directly only for analysis. So we don't actually, for these situations, host the data ourselves. We only access it based on need. I think for officially reported data, I don't think we have looked at cloud-based solutions yet, but maybe.
Yes, I think so just to complement, there are some types of data that we won't be hosting just because of the sheer size of the data set, especially genomics data. So the model is not to store everything at ECDC, it would not make sense. Yes, we explored this solution of leaving the data in other places, but there are other challenges. Like if you are to run some more advanced analysis, you are supposed also to reproduce your analysis. So if you do not store the data, and if for any reason those storing the data modify those data, you won't be able to reproduce your analysis. So it is a very important question. We don't yet have all the solution, I'm afraid. But
one of the challenges we've had during the COVID pandemic was the sheer amount of data that we received, because we were asking for case-based data, so 1 line per case, right? And like, I don't know, 50, 60 different variables at some point. And then we had 6 million cases reported a week. So quickly this built up to massive amounts of data. And the data storage part was relatively fine. The reporting system crashed, so we had to find solutions for that, and it was a very, very challenging time. But then analyzing the data and being able to produce a report in a timely basis, like we wanted to produce weekly outputs, we received the data on a Tuesday, we have to have the data analyzed on a Wednesday, published on a Thursday. So there was just no time, and just extracting the data was taking hours. Analyzing millions of records was taking hours to produce a couple of graphs. So this was a big challenge, and kind of maybe something we need to keep in mind when developing tools in the future as well, in case of kind of similar large-scale events where we need large amounts of data to respond.
I think we need to move to the panel discussion, but there will be opportunity at the end for further question to the panelists. So stay with us. Thank you, Gianfranco. Stay with us, and I will invite all the panelists to sit here with me. So Mercy, please. We had, Kamal, Dambinyan, Hamad. Tom, yes, please, join us. So, well, I can stand. All right, so I'm happy now to open the panel session. First of all, we'll have a few questions for our panelists, and then the floor will be open to the audience for further questions. So, I mean, I think we have representative for international CDCs, also national CDC, but also academics. And yes, maybe I think we missed an introduction for you, so I will leave you introduce yourself before we start.
Yeah, perfect. I'm Anne Cesagno. I work for the Tony Blair Institute, so we're embedded across about 18 member state governments, and then also support the Africa CDC on this work.
Welcome. So let's start. We have a few suggested questions. I don't want to start with the limitations and barrier. Maybe as a scientist, I prefer to highlight the key findings, and then we'll get there anyway. So the next one was the role of importance of standardization in digital health. I guess, we all agree that some level of standardization would be necessary to make sure, we've heard from Mercy and other, the fragmentation of the data and the systems that provides those data. But at the same time, you may think that, well, first of all, maybe digital tools can help naturally overcome those challenges. So you have some kind of meta system that will pool and with the help of some algorithm, record the data so you don't care if you have unstandardized data. And that maybe another argument would be too much standardization would create some type of monopoly and maybe hinder innovation. So I don't know who would like to start on this question of standardization. Merci.
Thank you so much. So I think my colleagues Binyam and Ahmad at really Obinyan presented on the standardization, the HIE policy and standards for Africa CDC, and this cannot really be overemphasized because, again, we cannot create interoperable systems without standardization, and COVID-19 has taught us that, you know, public health spans beyond just clinical data. We need data from different other sectors to be able to arrive at conclusive statements that can help drive policy and action. So if we definitely want to ensure that we can be able to interoperate with different systems, different sectors, we need to have those standards. We need to put up nomenclatures that are understood across board. We need to have policies, governance policies on the data, ownership policies around the data that actually support exchange of information. And again, I give you an example what we're looking at from a continental perspective, being able to exchange data and also pulling data from different member states to be able to have that continental picture of situations. If country A calls cholera acute watery diarrhea and country B calls it cholera, that's just a simple nomenclature or simple vocabulary that already has distorted the exchange. Or if I even have it in my system as COVID-19 and you have it in your system as SARS-CoV-2, you know, even though we are speaking to the same thing, but you've put the pathogen, I've put the disease, but the names are different. So we need to standardize how and that's why you have the ICD-10, we have the ICD-11 now that has been upgraded to help guide how we call diseases, we name diseases, we capture them. Again, around security standards, we definitely need to know the kind of systems, those measures that have been put in place around security for hosting. I'll give a simple example. If I'm an individual, take it from that very low level perspective, and I'm putting in my personal health data into a particular system. I want to know the standards that institution has put, for me to be able to guarantee my safety, my data security. And if we have a kind of an approach whereby a country could say, I have adopted the HIE policy and standard of Africa CDC, it gives me that confidence that those equipments, those parameters that have been put in place, those different things that have been considered meet the standards or meet that continental or global standard for me to be able to guarantee my security, and it builds trust as well. So standard builds trust. It builds, engagement. It improves engagement with different stakeholders, and it also helps, large-scale analysis and cross-sector analysis of data.
Well, I think you open many doors here because under the standard label, there are many different things. I've heard like minimum requirement for like data security, for instance. You could also mean standards in terms of content. You mentioned the ICD, so coding, but yes, like for infectious disease, we know that this coding may not be fully satisfactory, and you may link also with standards for laboratory results and testing, for instance. And the last part also is standardization in terms of agreement of the granularity of the type of data we want to collect. So I think Gianfranco mentioned the case reporting form that was proposed by WHO with the list of variables. We want to make sure that all countries are using the same. Anyone wants to? Yes, please.
Yeah, I mean, I'll take this from the political leadership side because we had a call to sort of drill this down into language for leaders. And I think to me what is really important about and exciting about this moment on standards adoption is that governments have lived it, right? Governments have lived through a proliferation of data, as we've just heard. Startups and other systems in their ecosystem have built their own apps for contact tracing. And so I think there's a real moment and window of opportunity with Africa CDC's leadership to use that to say, now we understand why we need standards. I think for a leader, depending on your minister or your head of state, they might not know HL7 fire, but what they will think about, what I think the driving force is standards are the thing that you hang your health system on, right? It's how you achieve everything else you want to do, and it's how you build care and improve health outcomes. And there's a real moment of, I think, leaders seeing the opportunity to drive that conversation about standards. I want an integrated picture of what's going on in my health system, and I want citizens to have access to their data in an integrated way. So how do we use that political will, demand from citizens who now say, got my COVID record in my pocket, but I want the rest of my data, which is sat over here from a different provider, to actually drive that adoption of standards. We could do the technical level work, but that political leadership level around standards is, I think, the real opportunity. I think weeks like this are good to learn from the innovation that has happened with the CDCs, with other governments, and how do we then build on top of that now that COVID has been this forcing mechanism for creativity. So that's how I would sort of think of standards, is take a step back. Where do you want to go from the last mile to the first mile? The standard is what helps you get there. Now go forth and tell your technical team to implement it and open up that conversation, which might have been closed before, on data sharing in a privacy preserving way. Again, because we've lived it in COVID and all these things popped up. Now how do we actually bring them back together to one shared standard so that you see that picture?
Thank you. Just a comment. I tend to agree with you, but I see many pain points. Like, I'm country X. I have, an accepted standard that is fit for purpose in my country, but an international organization is proposing something different. So for me, the opportunity cost is huge and with little benefit. So am I willing to take that next step? I think you wanted to, no. So,
I think mine was just on a lighter note. So when I had said Dr. Ahmad, I thought Director of CDC, African CDC, I thought I'd been promoted as a Director of African CDC. So I saw on a lighter note, when introduction was being like, they said Dr. Ahmad, Director of African CDC. I was happy. I thought I'd been promoted as Director of African CDC. So when you're talking about standards, maybe, you see, that's why it's good to have surnames. So you add surnames to it, then we know that, okay, Dr. Ahmad of HISP, that's Ahmad Abdulwahab, not Director of African CDC, just on a lighter note.
Thank you. Maybe we can move to another question. So, well, maybe I guess at some point we'll have to mention the limitation and the barriers that countries may face when trying to scale up those digital solutions. Who would like to start on this? Tom.
Yeah, hi. So I think there are several limitations that some of them have been mentioned here. One of them is just inadequate capacity to implement novel technologies. Like, we are increasingly talking about standards like HL7 fire standards. We have a very recent experience right here where I live. I live here in Rwanda, where we're trying to implement data exchange between clinical systems and EMR and lab information system using fire-based standards, and kind of just getting even basic capacity for mapping the data elements onto the fire profile can be quite challenging. So building those capacities in country to be sure that the capacities exist to leverage the novel technologies that promote health information exchange, I think that's really one key thing. And the other challenge that I would mention probably is just the policy environment, because sometimes as we increasingly are moving towards exchange of individual patient level information, just having the appropriate policies with data governance, data protection policies in place that ensure that these are correctly done, we exchange the right level of information, and even the use, governing the use, and issues around data sharing agreements, which I think Binyam talked about on the policy side. It's kind of playing catch up. So it's still, I would consider it as a challenge because the appropriate policy is just not in place to ensure appropriate data protection where this data exchange. Yeah.
Yes, thank you. I think, yeah, also the legal aspect can be very challenging. I mean, in Europe, we have a data regulation rules. The acronym is GDPR. And it's not meant just to cover health data, but many other type of data. And it's proven to be challenging for our work as well. Anyone wants to? Yeah, Merci.
Yeah, let me just add quickly. Now the train is on the One Health approach, especially when you're talking about early warning. And you're looking at how data from the environmental sector can actually provide some sort of signal towards some of the environmental events that we're currently facing. Or you're looking at maybe zoonotic diseases, and the data from the animal sector is kind of giving you a signal on what could spill over to the human population. I think there's been a little bit of a challenge in getting these different sectors to move together, especially around health information exchange. That has really been one critical gap where there's a lot of disparity across these different sectors. And the human sector is really far advanced, even with the standards, with the digital technology and all that. But how do we ensure that we are able to pull in information from these different sectors? And that's one of the issues that countries are having. If we are at different levels, we don't have these standards that can actually support us to move together, then there's really that huge challenge in getting this done. So that disparity across sector is a very big issue, especially using the One Health approach in early warning.
And I agree. And probably, especially when it comes to animal health, you have within that field different types of challenges. I mean, if you're talking data for wildlife, maybe challenges in terms of even systems to collect that information. When it comes to more like the food industry, it's clearly with some commercial interest and other type of data protection issues. Anyone else wants to comment on this? Gianfranco.
Yes, and I think in Europe we've also faced kind of on the One Health approach. What I'm thinking is with HappyPass, for example, and wanting to share information across different sectors, then the question of sensitivity of specific pieces of data and access to kind of bits of data becomes more and more important. So then you need to think about what your stakeholders are able to see, and maybe they need to report some sensitive information which cannot be shared more widely, but then you need to be able to use that information to provide the situation awareness on a particular event, for example. So we've been struggling at ECDC on how to deal with this and with making sure that the right person and the right sectors get all the information that they need, while at the same time kind of keeping sensitive data as restricted as we can.
Yes, maybe moving to the next question, but I think it's a nice opening. This intersectoral and what is the role of those other actors? So it can be also, animal health, but also since we have people from academia, what's the role of the private sector in this digitalization of public health?
That's fine. Okay. Yeah, I think when you say the private sector, I think it's a bit very wide. Maybe we can divide the private sector and look at it. You have the conventional for-profit private sector, and then maybe you could also have the other group of the NGOs, partners working on this. So, and I think the interests are different. So when you look at the conventional organizations like HISP, where I come from, HISP, I think some of the challenges that were highlighted are some of the areas that they can contribute. Especially, most of those organizations are known for providing technical support. So, and then this technical support is going to be in different areas. So it could be in the form of developing new solutions or trying out implementations, seeing that you have solutions that are fit for purpose, that are cost effective, and aligned with the country needs. Because sometimes we are now having, like what they said, epidemic of pilot projects now. But no, you want to have projects that are solutions that are fit for purpose that countries can be able to use. And I think those organizations will be able to provide us support. So apart from providing technical support, you also have issue of advocacy, trying to actually get people to promote this concept of use of data for decision making, so that if the political class actually see the benefit of using data, maybe that will also help in terms of the use of data. So when you come to the for-profits, if I just jump and I go for the for-profit, the conventional private sector, like for instance, the telecom. I think telecom, for instance, has a very central role in terms of what they can support to be able to advance the course of digitalization. There is this what we call zero rating, where you have some particular software they will be able to access. I mean, the URL can access certain sites without paying. So now that will go a long way because people don't have to now worry themselves to be looking for data to be able to actually either update data. So this one, I'm just restricting digitalization within the context of health information system. Digitalization is much, much wider, but I'm just looking at the restrictive interface of health information system, where, for instance, in terms of reporting, you could have like the telecom sector will be able to support. And if you go beyond the telecom sector, there are a lot of infrastructure gaps. You could have some different arrangements whereby states or government offices will be able to have access to tools in terms of there's going to be arrangement that they will be able to access it in a way that it is not going to cause any financial hardship. So you could have those arrangements, and they have a lot of things that they can do to actually help the health information system. Just to give a couple of examples on that. Thank you.
Just maybe I have a question, follow-up question for you. How do you see the, I mean, there is a very fast-moving field now, which is the use of individual health data by private companies. It's collected through, well, many of the apps we're all using with a subscription or not. So now you can subscribe to an online consultation, or you access your lab data and whatnot. Now, most of it is done for individual health at best, maybe with or without profit. How do you see the link with public health? So how do we allow, like, public health institution, Ministry of Health, to have access to some of this data for public health action?
So I think, you see, there's going to be a conversation between the private sector and the public health to sit down and look at exactly what is it that we want to achieve. And then you try to leverage on the comparative advantages of the private sector. That's what you want to leverage on to be able to enhance public health intervention. So it's not going to be just give the prescription and say this is how you go. But I think the first thing is sit down with the private sector and see what are those things that you can be able to leverage upon so that it will be for the benefit of public health. Thank you.
Maybe you would to continue also on the...
No, so I just gave the two, and I know because of time, there's the academia part. Maybe I can't be talking when an academic is here, so that I don't go into something.
I leave that between you two.
Good. Maybe as I am from academics perspective, I would say if I have to mention, I would mention two things. The first thing we have to contribute is on evidence generation, like we saw previously in the digitalization of Africa on the health information exchange. If you see that, we really need to generate evidence like what works and then what doesn't work. Because, like for example, we have now the standards which we adopt, we have the policy recommendations, but we don't know like which one really work in what kind of setting. So those kind of evidence generation is, as universities also having that all methodological skill, I think those kind of contributions are very, very important. At the same time, whenever we do that, I think embedding capacity building within that process, I think generating more digital health experts. They can be experts who can work on the ground, or they can be high-level experts who can do like strategic developments for digital health. Those kind of experts can be trained in between. That's why in my presentation also we're highlighting the need to develop a kind of an informatics fellowship so that we can have like a future cadre of informatics professionals that can drive digital health and then technology deployment in African continent. Just to add that, thank you.
Thank you very much. I think we are running out of time, but I want to finish on a positive note. So I would like all of you maybe to identify one opportunity for the continent when it comes to scaling up digitalization. I don't know who would like to start. Maybe you, Tom. You are the first on the right. So.
Yeah, so one I think has been mentioned earlier, or I think it was in a previous talk where somebody talked about so many pilots that have been done which have been shown to be successful. The challenge is that they've not been taken at scale. So if there are those kind of opportunities, especially mobile technologies, because as we're talking, for example, about case reporting from the lowest level, some places where we may have challenges with electricity or with internet connectivity, we can leverage some of those mobile solutions and take them at scale to help improve case reporting and just improve surveillance. So I see a great opportunity there.
Thank you, Tom. Mercy.
I don't know why I'm so passionate about the young people on the continent, but I feel like that is one of the very big opportunities we have as a continent. We have a very fairly young age group. Over 70% are below 40, like I said before. And so we really need to harness this demographic dividend for the continent and try to see how to engage the young people in promoting digitalization. I think one of the ways that we can do this is to engage them in the digital solutions that we've developed, bring them for consultative workshops like this, give them that space to look at things from the perspective, because imagine that 70% of the population on the continent is using the digital solution, then we are good to go. So if we bring them, we give them these opportunities, give them the platform to look at some of the solutions and also give in their remarks and, make those recommendations that really would work, I think that would really be a very great opportunity to scale up.
Thank you. Ahmad.
Yeah, thank you. So maybe let me give it from the perspective of where I work now. I work with these very senior political people. And one thing I noticed, which was why I asked that question, is more often than not, people say we give the political class data, but somehow they can't figure it out in terms of what exactly it means. And I think with the advantage of digitalization, we have opportunity of actually presenting data in a form that they don't have to think so much. I mean, this visualization that we do, that easily they will be able to actually comprehend what message we want to pass to them. So, and then secondly, because of digitalization, the data can be at their palm top on their phones. That means if we have tools in such a way that all what they need is to just press something on their phone and they can see the data they need. So I think that is one great opportunity that I think we need to leverage on, because if information is being used for decision making and the political class are now demanding, then all this issue around quality of data not available, all this. So we're going to have it being driven also from the top. Thank you.
Binyam.
Well, so if I have to mention one, I would second what Mercy say. All the young talents who are coming to the continent, they are, I think, as a hope. So as a person teaching like all young talents on digital health and health information systems, I always teach them like innovation, and then whenever we give them few assignments, and then whenever we see what kind of solutions they develop, it always amazes me, and I always feel that the future depends on them. Thank you.
Thanks.
Thank you. I'm not sure I'm the right person to talk about Africa, but kind of what I want to say is there's an opportunity for international collaboration, right? But I mean, the development on the digital side is something which we're all facing more or less at the same time with the COVID pandemic and the expansion of all these digital tools. So I mean, we've already started working together, and I think we should really look at further operationalizing it and kind of implementing it in practice and seeing, as we go along, learn from each other's mistakes and then find solutions which work on both sides. And it works, of course, both ways.
Thank you. I won't call you Cherry Blair, but I've
That's fine. When you go last, you get to echo points that people have always made, which is interesting. I mean, I would take your point on, yes, there is an opportunity cost to digitization and to standards adoption, but there's so much opportunity. So I think the challenge for partners is go on that long journey with public health institutions. So the one I would echo that I think is really exciting for the continent is all these digital natives, right? Yes, there are digital skills gaps. We have all these digital natives. How do we get them into government, into public health institutions, innovating not just in their startup or in their home, but building all those skills, right? We can build a cadre of talent on the continent that's doing HL7 Fire and whatever is next. So I think that, for me, is the really exciting opportunity that cuts across all of us. So thanks.
Thank you very much. I think there is one burning question from our colleague here. So,
by profession, I am not digital or AI expert, but definitely I am a virologist. And I have been doing a lot of preclinical and antiviral drug development in a clinical studies also. I definitely want to add that our brain is more intelligent than any software. So we have not to discriminate that human brain is inferior. Definitely, we are superior than digital or any kind of a software. For example, in a clinical trial, there are inclusion and exclusion criteria where mothers who are feeding the breast to the baby, they are not included in the clinical trials as a volunteer. In the same way, HIV patient who has to declare that he is a HIV patient or not. So there are many people, they don't want to reveal their information, correct information, you know. So if you just take the data from such kind of a people, of course you have a lot of errors, you know. The data quality is not error free. So we have to always double check that whatever the data we are transmitting, especially in the healthcare system, we have to double check with our mind. We have not to be dependent totally on the software or digital. This is my question. Thank you.
thank you very much. So I feel better now. Will not be entirely replaced by machines.
Thank you. Very good.
I would like to thank all the panelists for this very interesting discussion. And I wish you all a very good proceeding with the conference.